Thank you. After the unexpected event, I will take the podium to address my presentation. I will try to highlight what we have learned after the large pragmatic trials in schizophrenia. I hope, at least I hope, to keep you awake in a more decent and polite way than this on the picture, but Yelena saved me, so everything is okay now. Thank you. These are my disclosures: Vice Honoraria, Research Grant and Advisory Board. And now we can see what everybody was trying to do to treat schizophrenia over the past years. Some very radical solutions, as we can see in the first picture, right here. And then psychosurgery and things like that. Or some more unusual efforts, like Freud here in this anecdote sketch, offering cocaine to one of his patients, psychosurgery, or hypoglycemic comas for our patients. On the other hand, these are the hallmarks in the development of antipsychotic therapy, starting with rezapine in 1940, and then with chloropromazine by the three guys I showed you in the previous picture in 1952, and then the establishment of clozapine in the early 70s. Clozapine, as the first atypical antipsychotic, gave us hope that we could treat the positive symptoms, the negative symptoms, and the cognitive deficits without causing extrapyramidal symptoms or elevating prolactin levels in the blood. The more ambitious of everybody is the politicians, and what a politician, a very known and popular politician, has said, that antipsychotics made it possible for most of the mentally ill to be successfully and quickly treated in their own communities and returned to a useful place in society. As we can see, this is not the case. JFK was very ambitious also. What we have done so far, through our medicine, we could manage or try to manage dopamine dysregulation and alleviate positive symptoms, but not having any effect on negative or neurocognitive symptoms. Talking about schizophrenia, we can't miss to refer to people suffering from schizophrenia, but they did something great in their lives, like John Nash, Václav Nizinsky, and Sid Barrett, and a lot of other people suffering from schizophrenia. Let's see something about the studies conducted from 1960 till now. This is a study that was published in 2013, and as we can see over here, there is a growing number of studies concerning schizophrenia, of individual reports, of trials, etc. The schizophrenia reports published in the leading general medical journals like BMJ, JMA, New England Journal of Medicine, and The Lancet is growing also. What are these publications about? They are about intervention, mainly drug interventions, followed by psychological therapies, other somatic treatments, or policies or care packages. We try to measure things in these trials, and this is done mainly by using scales. The most known scales used in schizophrenia is the BPRS and the PANSS scale. They are widely used. The number of studies is growing from 2000 to over 12,000 in 2008. And if we could see something more about these studies, we can see that the average number of studies per year is growing from 35 in the decade between 1950 and 60 to over 650 in the decade starting in 2000. Concerning the language that is written, these studies are written, they are mainly written in English, and now there is a growing number of studies written in Mandarin coming from China. That is the slide that shows where these studies are conducted, mainly in the United States, followed by China, Europe, and then the United Kingdom. Coming to the number of participants, average number of participants per study, this is also growing from 65 to 132. This is the average number. That is all about our studies and what we can do. Let's see something about the explanatory studies versus pragmatic trials. The efficacy studies aim to determine whether an intervention can work. They are broadly used by the pharmaceutical companies in order to get an FDA or EMA approval, and the patients are highly selected. The primary outcome is mainly symptom reduction. On the other hand, pragmatic trials reflect the realities of the setting where the intervention is going to be used. The subjects have a broader range of characteristics, so they represent a group of people that mainly would benefit from the specific intervention. The follow-up is for a longer period of time, and the primary outcome goes beyond symptom reduction, and we can examine quality of life, time to discontinuation, etc. So the efficacy studies try to answer to the question, can it work? And the pragmatic trials try to answer the question, does it work in the normal setting? That question tried to answer the specific CATIE study. It is a very well-known study. It is the clinical antipsychotic trial of intervention effectiveness. It was conducted from January 2001 to December 2004 in the United States. It was for about 18 months, and it had 150,500 patients. The primary outcome was time to all causes treatment discontinuation, and the secondary ones were discontinuation cause, psychopathology, safety, neurocognitive disorder, cost and health services use, adherence, comorbidity, quality of life, and substance abuse. This is the study design with inclusion and exclusion criteria, and this is the randomization where they started with the patients double-blind, randomized to olanzapine, quetiapine, risperidone, ziprasidone, or the first generation antipsychotic perfenazine. The phase 2, the patients who discontinued the drug, they were either randomized to receive olanzapine, quetiapine, risperidone, or clozapine. Instead of clozapine, they could choose to receive ziprasidone with the clinician's decision also. And in the phase 3, it was an open phase. They could choose the drug that they were assigned to. This is the paper for the study design. The CATIE study, it is true that drew attention from the media and the public. This is the editorial from the New York Times in September 2005, because it compared first generation against the second generation antipsychotics, and the findings were very interesting. We will see them in a few minutes. And except from the media, it had an impact on, in literature, in psychiatric literature, with more than 80 articles, more than 1,600 citations. There is a book used as an archive of the study's results and implications. There are several more randomized trials comparing the effectiveness of antipsychotics. There are meta-analyses of the CATIE findings, and finally there are critics and commentaries on its methodology. This is a table of some of the studies that followed the CATIE and used its population. We'll see something about that later on. And talking about numbers, the analysis sample was 74% male, with a mean age of 40 years old, and 60% of them white, the rest of them black and other. 60% of them were never married, and 74% of them completed high school, and the mean baseline total punch score was 75.7. The reason of discontinuation, all cause, was 74%. Due to lack of efficacy was 24%. Due to intolerance, it was 15%. And the patient's decisions was 30%. In this table, you can see the mean dose, the dose range, and the percentage of patients at maximum dose during the KT, the phase 1 study. And we can see that for several drugs were used in a rather low mean dose, and the dose range was rather low also. That could explain the specific results of the KT study, because it shows that risperidone, for example, who had a mean dose of around 4 milligrams per day, had a discontinuation rate of 28% due to lack of efficacy, and also it had 15% adverse effects rate. These are all the results for all the drugs. Coming now to the assessment of psychopathology in the KT phase 1 study, we can see that there is a reduction, in the PANSS score all over time, and it seems to be continuing over the period of the study, the 18 months, that is. But although there is a reduction in the PANSS score, there seem to be some relapses during the study period. The rate of extrapyramidal symptoms related discontinuation is higher for perfenazine. That is very logical, of course. And another logical slide is that the rate of weight gain and metabolic syndrome related discontinuation was higher for olanzapine. That is why psychiatrists love to be more logical than other people. That's what we like to believe, though. The advantages of the KT study, it is that it's a large study sample. It has a large study sample. It has a complex design, multiple parallel arms, 18 months duration. Experienced researchers did the work, and it was state funding from NIMH. That means that it didn't have much bias from the pharmaceutical companies. There are limitations, of course, of the KT study. It has a disputable value of discontinuation as measure of effectiveness. 74% of the patients were male. 3/4 of them were already stabilized patients with medium severity symptoms. They had impressively high discontinuation rate. Typicals were represented by perfenazine, not a drug that we prefer to use in our everyday clinical practice. The patients with signs of tardive dyskinesia were excluded from the perfenazine arm, and open-label administration of clozapine was a problem. Also, the general problem was in blindness. The last limitation is that a small number of patients were put in the ziprasidone arm. Conclusions now coming from the KT authors. The most usual cause for discontinuation was patient's decision for reasons not specified, followed by lack of efficacy and adverse events. Olanzapine has the highest probability for prolonged therapy. Perfenazine was equally tolerated and efficacious in comparison to atypicals and significantly cheaper. Clozapine had the highest probability for remaining under therapy in patients who discontinued phase 1 because of inefficacy. There was no difference in the outcome between patients with substance abuse and the rest. The neurocognitive deficit responds in a similar way to all agents with a high superiority for perfenazine at 18 months. Some critique for Katie, the critique first and then the reply. The majority of patients were under atypicals without satisfactory response at baseline. The reply for that is that at least patients under olanzapine and risperidone who were randomized to the same agent had better outcome. A second critique is that more patients were under olanzapine before joining the study, and this is reflected in the patients' rates remained under the same agent after randomization, olanzapine 25% versus risperidone 19%. The reply to that is correcting the analysis for this factor did not change the results. Some people say that the things you cannot see are the things worth looking at. And let's have a look at KT studies results under this concept. It seems that 15% of patients with tardive dyskinesia were not randomized to the perfenazine arm. That means that if we correct that, would add 15% to the discontinuation rate for perfenazine. 40% of patients manifested metabolic syndrome, preferentially under olanzapine. That means a correction to that would add a 5% discontinuation rate for olanzapine. This is a very hard correction and means that 1/3 of patients under olanzapine will discontinue because of the metabolic syndrome. Blindness was problematic. Administration once a day results in close 15% lower discontinuation rates in comparison to 3 times per day. If we correct all these, the primary outcome for treatment discontinuation for any reason would be around 80 rather than 74%, and it would change also the percentages of the drugs used in the study. We're not done with the critic. We are about to continue. Patients under olanzapine received the maximum dose at higher rates than the other drugs. Only 44% of patients under quetiapine and 48% of patients under ziprasidone received maximum allowed dosage. Only 40% of patients under risperidone received maximum dosage, in spite of the fact that risperidone had the lowest discontinuation rate because of adverse events, but also the lowest efficacy. That means that we try the drugs in higher dosages, and this could also influence the results. And going on with the critic, I am probably making some fuss today. I'm not in a good mood. I'm up here and criticizing everything. Isn't that right? Clozapine was given open label. General blindness was problematic because of different administration schedules. It is highly possible both the patients and the therapists to know which was the agent that the patient was taking. Ziprasidone entered the study too late to have valid conclusions, and there was no placebo arm, and the response to therapy was generally low, around 11 points in total PANSS score. Some special issues about the KT, I won't stay in this, but it seems that after 18 months treatment, there was no difference between agents, with patients under perfenazine being slightly better. I reminded you that perfenazine is a first generation antipsychotic. This is rather peculiar. And the relapse rates seem to be high, although they were in the study, they were observed, they were rather adherent to the treatment. And it seems in the best that during 1 year, everybody, even with a good result, would have at least one relapse. This is the arm of olanzapine. Some solid conclusions from the KT. The most controversial finding of the KT study was lack of significant differences in effectiveness between most of the second-generation antipsychotics and perfenazine. The most robust differences observed between drugs were in the rates of side effects, particularly weight gain and laboratory measures of cholesterol, triglycerides, and prolactin. The KT study showed that each drug might be most useful in particular situations. For patients whose symptoms did not improve with first-line treatment, clozapine was most effective. Keep that in mind. We'll discuss it a little bit later about that. Olanzapine was effective in all phases of the study, but clozapine had the greatest side effects liabilities. Some other conclusions say that for patients who switched medications because of side effects, the best alternative depended on the type of the individual side effects profile and the severity of the patient's illnesses. Risperidone was effective overall for people who discontinued prior medication as a result of intolerability. Quetiapine worked well for people who did not tolerate perfenazine. Ziprasidone demonstrated the most favorable metabolic profile, and perfenazine, because it was priced as generic, was the most cost-effective drug in the study's main phase. This was the Katie study, a large pragmatic trial, and let's see what comes after Katie. It seems that we are blocked in these findings because everything was rather familiar to us. So what can we do? How could we get this truck out of the parking? Or else how did it get there? Let's see. Some specific issues, like the substance misuse in Katie. I mentioned before that there was no difference between people with substance abuse and the results of Katie, and with those who didn't use illicit drugs. This is not the case if we try to separate these patients into three categories: those with moderate or severe drug use, those with mild use only, and non-users of illicit substances. That goes to what Oscar Wilde said, that the pure and the simple truth is rarely pure and never simple, because we saw some other results in the Katie, but now what we can see by a further analysis is very simple, isn't it? But we can't see it. Let me tell you something. It is that when we divide the subjects into the three groups, the group that used illicit substances at the time of study entry tried to be younger, male, non-white, and less educated, with more severe mental health problems. And this seemed to continue all over time, with the same group having poorer outcomes in the domains of psychosis, symptoms of depression, quality of life, and that, if we may go a little bit further, it would seem that a harm reduction approach for individuals with schizophrenia would be beneficial. These two are schizophrenics. They are both schizophrenics. They look alike, but people with schizophrenia don't look that much alike. So we try to separate and see what drug we can use to what patient. This is another publication coming from the Katie population, and tries to see what the characteristics of the population that we used as psychiatrists clozapine would be. Clozapine, we know it is very highly effective, with a low EPS rate generally, but with the adverse events being rather confusing. And it seems that only few people down here entered phase 2E and received clozapine, only 86 people out of 1,050, I remind you. And what were their characteristics? They were mainly male, with a higher score in PANSS and CGI, with a higher score in AIMS, the scale for extrapyramidal symptoms. They had more inpatient visits and and outpatient visits, so they used the healthcare system more intense than other people. So what we can find from this is that we tend to keep clozapine as a secret agent, a secret drug that would be used in difficult cases, and that's not the point. Coming to tardive dyskinesia and drug discontinuation, there was no difference in the rates of discontinuation due to tardive dyskinesia, and the population that had tardive dyskinesia tend to be more old, with more years and more severe of the illness. Let's see now the effect of the Katie study in real life. Given its startling results and the extraordinary attention that it attracted, one might have expected that Katie study would have a profound effect on clinical practice. That's not the case, because, as we say in Greece, logic is a psychiatrist's delusion. We are not very logical in what we do. This comes from New York, and they tried to see how the Katie results changed or did not change the prescribing habits of psychiatrists. And coming for the first generation antipsychotics, there was no change to the years from 2006 to 2009, and a slight decrease for olanzapine during these years. Coming to another large study to replicate the same results, it showed also a slight decrease in olanzapine, a slight increase in aripiprazole use, and a rather slight decrease also in risperidone through these years. So did anything change after Katie? This is a meta-analysis trying to check if anything changed with the Katie and the Atlas studies results. And it seems that concerning risperidone, olanzapine, and sulpirid, nothing has changed after these studies. We tend to do what we know we can do and what we want to do. Obviously, you can't read that because it is in Greek. It's all Greek to me, they say in the States and in the United Kingdom. So let me translate it. It says that either we find the road or we create one. So we are determined to create a road for a better treatment. The final conclusions coming here is that pragmatic trials so far, excuse me, this shouldn't have happened. It flew out of the sky. Let me do that. Sorry. So, pragmatic trials so far tend to replicate mainly things we already know. First of all, that first generation of the psychotics are more likely to cause extrapyramidal side effects. From the second generation antipsychotics, some cause metabolic problems and other problems with prolactin that finally affect treatment adherence and, of course, treatment results. Clozapine is underused. The results from large pragmatic trials did not change the way we use antipsychotics, so we should try to fit the treatment to the patient and not vice versa. Otherwise, this will fall on our heads. We'll look like that poor guy trying to do what he already has in his hands. Thank you. Thank you for your attention.